Level 1, third year medical student. You have a short white coat. The length is not decorative. It is a signal that you are not yet a doctor, and everyone in the hospital knows it, including you. Your coat has 2 pockets. One has a pen light, one has a pocket reference guide to clinical medicine that is 1,200 pages compressed into something the size of a paperback novel, which tells you something about how much you are expected to carry and how little space you are expected to take up. You're 23. You spent the first 2 years of medical school in lecture halls and anatomy labs, learning the theory of a body before you were permitted to encounter one that was alive and unwell and asking you questions. Now you are on the surgical rotation. It is 6 weeks. You will rotate through general surgery, and then orthopedics, and then you will do a week of vascular, and at the end of it, you will take a shelf exam that covers everything you saw and everything you didn't, and some things that were not in the rotation at all. Your first morning starts at 4:45 a.m., not because your attending told you to be there at 4:45 a.m., because the residents told you that the attending arrives at 5:15 a.m., and you should be there before the residents, and the residents are there at 5 a.m. You work out the math in the parking garage in the dark. You are in the hospital at 4:42 a.m. The attending arrives at 5:20 a.m. Nobody acknowledges the discrepancy. Morning rounds move fast. The team walks from room to room at a pace that is not quite running, and you follow at the back, trying to hear what the senior resident is saying to the attending, while also reading the chart you were given 20 minutes ago for a patient whose condition you do not fully understand and whose name you have already mispronounced once in a hallway. The attending asks you a question mid-stride. The question is about the mechanism of action of a drug you studied 8 months ago. You give a partial answer. The attending nods and moves to the next room. You spend the rest of rounds trying to determine whether the nod meant correct or meant that the attending has already stopped thinking about your answer. You are in the operating room for the first time on day 3, a laparoscopic cholecystectomy, gallbladder removal. You are assigned to hold a retractor. The retractor holds tissue out of the way of the instruments. You hold it for 40 minutes without moving. Your arm begins to shake slightly around minute 25. You hold it still through the shaking. The attending does not look at you. The scrub tech does once and looks away. The surgery takes 43 minutes. When it ends, the attending says, "Good job" to the room in the way people say good job when they mean the procedure went as expected. You are not sure if that includes you. You decide it does. You write your patient notes in the EMR after rounds each day. The resident edits them without comment. You read the edits. You try to understand what changed and why. Some of the changes are about accuracy. Some are about how things are said in medicine, which is a language that sits inside English but operates by different rules. Specific, passive, precise, stripped of anything that sounds like uncertainty, even when uncertainty is the most honest thing available. You are learning that language. You are not fluent yet. You will not be fluent for years. You go home at 7 p.m. on the short days. On the long days, you go home at 9 or 10. You study for 2 hours after you get home. Then you sleep. Then you do it again. You are not being paid. The cost of the education you are receiving is $62,000 per year. You are paying to be here. That fact lives in the background of every early morning and every late night. And you have learned not to think about it directly because thinking about it directly doesn't change the math, and the math doesn't change what time rounds start. Level 2, Intern, PGY1. You matched. That sentence means more than it appears to. Matching into a surgical residency is a process in which you ranked your preferred programs, and the programs ranked their preferred applicants, and an algorithm reconciled the two on a single morning in March that the entire medical community calls Match Day, as though it is a holiday, which in some ways it is, and in some ways it is the opposite of one. You matched into a general surgery program at a hospital that was your third choice. You told everyone it was your second choice? Nobody checked. You're 26. You have a long white coat now. You have an MD after your name on your badge. Both of these things are true, and neither of them changes the fact that on your first day as a physician, you do not feel like a physician. You feel like a medical student who has been handed a pager and told that the calls coming to it are now your responsibility. Your salary is $62,000 per year. You divide it by the hours you will actually work. You do this math once, you do not do it again. The intern year in surgery is defined by one primary task, SCUT. The word is used openly, without apology, by everyone above you in the hierarchy. SCUT is the work that needs to be done and that you are the most available person to do. Discharge paperwork. Blood draws when the phlebotomist is unavailable. Consent forms at 11 p.m. for a case scheduled at 7 a.m. Calls to consultants to relay information that the senior resident could relay themselves in the same amount of time it takes them to ask you to do it. You do the SCUT. You do not complain about the SCUT. Complaining about the SCUT marks you as someone who does not understand what internship is for, and what it is for, among other things, is learning that there is work beneath your training level that still needs doing, and that the person who does it without complaint is building something that cannot be built any other way. You are post-call on a Tuesday. Post-call means you worked overnight, which in surgery means you worked from 6 a.m. Monday to sometime between 10 a.m. and 2 p.m. Tuesday, depending on what came in overnight and what the morning looked like and whether you were able to finish your notes before rounds ended. You have been awake for 28 hours. You are driving home. You are not falling asleep at the wheel. You are something adjacent to it, a state that has no clinical name, in which you are technically conscious and functionally impaired and aware of both things, and continuing anyway because there is no alternative that makes sense given the distance between the hospital and your apartment. You get home. You eat something from a container you do not remember putting in the refrigerator. You set an alarm for 4 hours. You sleep. The alarm goes off. You go back. There are things you are learning that cannot be learned any other way. How to place a central line at 2 a.m. with your hands steady and your mind clear when your body has been awake for 19 hours. How to deliver bad news in a hallway with a family who was not expecting it. How to be present in a room where someone is dying when everything in your training was designed to prevent the dying, and now the dying is happening anyway, and your job is to be there fully, without flinching, because the patient and the family need someone in that room who is not afraid of what is happening. These things are being built into you through repetition and exhaustion, and the specific kind of learning that only happens when the stakes are real. You do not have a word for this yet. You will later. Your program director says the intern year is the hardest year of your life. You are inside the intern year right now, and you are not certain they are right, and you are not certain they are wrong, and you do not have enough distance from it to tell the difference. Level 3, Junior Resident, PGY2. You have survived the intern year. That sentence is not dramatic. It is a description of what happened. Approximately 3% of surgical residents leave their programs in the first year. Some leave for other specialties. Some leave medicine entirely. You did not leave. That is a fact about you that you understand more clearly now than you did when you started, which is that staying is not the same as thriving, but staying is the prerequisite, and you stayed. You're 27. The SCUT has not disappeared. It has redistributed. There is a new intern now who does the worst of it while you supervise, which means you are doing slightly less SCUT and slightly more of the thing that will define the next 4 years of your training. Operating. You are in the OR more than you were as an intern. You are still assisting more than you are operating, but the ratio is beginning to shift, and the shift is the only thing that makes the hours make sense. You can do an appendectomy, not independently. There is an attending in the room, but your hands are doing the work. You have done 11 appendectomies. You remember each of them in the specific way surgeons remember early cases, which is by what went wrong or almost went wrong or what you did differently than you'd been taught and had to correct mid-procedure while the attending watched without intervening. The attending watches without intervening until the point at which intervening becomes necessary. You are learning to feel where that point is before you reach it. The hours are 80 per week. This is the regulated limit. The limit was established after a series of studies showed that residents working more than 80 hours per week made significantly more errors than residents working fewer hours, which led to a regulation capping the hours at 80, which led to a generation of residents who work 80 hours per week and document 79. You work 80 hours per week. Some weeks, you work more. You document what you document. Your co-residents are the closest thing you have to a peer group. You have approximately 4 friends outside medicine. You have not seen 2 of them in 8 months. The other two you see at occasional dinners where you arrive late and leave early and spend a portion of the meal answering pages on your phone while apologizing for answering pages on your phone. They say they understand. They do not fully understand. You do not explain it because explaining it would take longer than the dinner. You are beginning to develop a sense of what kind of surgeon you want to be. This is different from knowing what specialty you will pursue, though it includes that. It is a question about approach, about whether you are the kind of surgeon who moves fast and clean and trusts your hands, or the kind who is slower and more deliberate and trusts the plan. You are still learning which one you are. Most residents don't know until their 4th year. Some don't know until their 1st year of independent practice, when there is no attending in the room and the decision is entirely yours and the answer reveals itself in the moment of choosing. Your loans are $310,000. You are not paying them down on a resident's salary. The interest is accruing. You have a spreadsheet. It is different from the kind of spreadsheet you thought you would have at 27. It does not have a column for net worth. It has a column for interest capitalization rate and a column for projected balance at the end of residency and a column you labeled future problem that contains a number you have not looked at directly in 3 months. Level 4, Senior Resident, Chief Resident Year. You have been in surgical training for 4 years. You are about to find out what 4 years actually built. You're 29. Your salary is $72,000. The number has not kept pace with what you now know how to do, which is a structural feature of residency and not an oversight and understanding that distinction is one of the things the 4th year is quietly for. You are the senior resident on the trauma service this month. That means when the trauma pager goes off at 2 a.m., it is your assessment that matters first. The attending is available by phone. The attending trusts your assessment enough to wait for your call, rather than coming in before you call. That trust is not given. It was built across 4 years of smaller decisions, and you feel the weight of it now in a way you could not have anticipated feeling it when you were the intern following rounds at the back of the team. A 34-year-old comes in through the trauma bay on a Thursday night. MVA, blunt abdominal trauma, vitals destabilizing. You do the primary survey. You order the imaging. The CT shows a splenic laceration, grade 3, and free fluid in the pelvis. You call the attending. You give the presentation in the specific compressed format that surgery uses: age, mechanism, relevant findings, hemodynamic status, your assessment, your plan. You do not editorialize. You do not express uncertainty you have not already resolved. The attending asks 2 questions. You answer both. The attending says, "Proceed." You proceed. The splenectomy takes 58 minutes. The attending is in the room. The attending's hands are not on the patient. That is new. For 3 years, there was always a moment in every case where the attending's hands came in and corrected something, or guided something, or simply took over the part that mattered most. Tonight, the attending stands at the edge of the table and watches, and the only intervention is one quiet word about the angle of your left hand at minute 41. You adjust, you finish. The patient goes to the ICU stable. You drive home at 5 a.m. and you do not feel tired in the way you felt tired as an intern. The exhaustion has been integrated. It is part of the baseline now. What you feel instead is something that takes you a moment to name: competence, not confidence. Confidence is something you perform for patients and families and junior residents who are watching you for cues about how worried to be. Competence is different. It is quieter. It is the accurate knowledge that your hands and your mind can be trusted to do what the situation requires. You have not felt this before, not fully. It has taken 4 years. The chief year also means administration, scheduling, managing the interns whose confusion you now see clearly was also your confusion 18 months ago. Writing evaluations. Running Morbidity and Mortality Conference, which is the weekly meeting where the department reviews every complication and every death from the previous week, not to assign blame, but to understand what happened and what could have been different. You have presented at M&M. You have stood in front of your attendings and your co-residents and said, "Here is what I did. Here is where it went wrong. Here is what I would do differently." The doing of that is different from the watching of it. It requires a specific willingness to be accountable in public without becoming defensive about the accountability, which is a skill that is not in any textbook and that the chief year exists partly to teach. You are applying to fellowship programs. You have chosen a subspecialty, cardiothoracic. The match process will happen again. Smaller this time, narrower, but the same algorithm and the same March morning and the same question about whether the number on the list will resolve into the outcome you need. You are 30 days from the end of your residency, 5 years from the day you started. You are a different person than the one who held the retractor for 43 minutes and wondered if the nod meant correct. You know it meant correct. You know because you have given that nod yourself to the interns holding retractors behind you, and you know exactly what it means. Level 5, Cardiothoracic Fellow. Fellowship is voluntary. This is technically true. Nobody required you to do 2 additional years of training after 5 years of residency. Nobody held the choice in front of you as a condition of continuing. What happened instead is that you chose a subspecialty that requires fellowship, which means you chose a path on which 2 additional years were structurally inevitable, which is a different kind of requirement, and understanding the difference is one of the things that 29-year-old you was not yet equipped to do. You're 30. Your salary is $78,000. You are operating on hearts. The first time you hold a heart in your hands, it is stopped. The patient is on bypass. The perfusionist is managing the circuit that is doing the work the heart cannot do while you work on it. The attending is on the other side of the table. You have trained for 5 years to be in this moment, and the moment is different from the training in the way that all important moments are different from their preparation. More specific, more quiet, more dependent on the particular steadiness of your particular hands on this particular afternoon in this particular chest. The learning curve in cardiothoracic surgery is longer and steeper than anything you encountered in general surgery. This is known. It is discussed openly in the literature and in program interviews, and by every attending who has supervised a CT fellow for long enough to watch the curve. What is not discussed openly, because it cannot be described in advance in a way that means anything, is what it costs to stay on the curve. The precision required at this level is of a different order than what you built in residency. A millimeter in a coronary anastomosis is the difference between a graft that functions and one that fails. You are learning to operate in millimeters. You are 30 years old and you are learning to operate in millimeters, and you have been in training for 7 years and you are still learning. The hours have not decreased. The regulation that capped residents at 80 hours per week does not apply to fellows in the same way. You work what the caseload requires. Some weeks, that is 75 hours. Some weeks, it is more. You have stopped counting the weeks against each other. Counting them was a habit from residency that made sense when the endpoint was visible. The endpoint is still visible from here. It is closer, but 2 years in fellowship after 5 years of residency, after 4 years of medical school, after 4 years of undergraduate is a total of 15 years between the decision to become a surgeon and the day you operate independently. You understood this mathematically before you started. You understand it differently now from inside it, watching the years account for themselves one case at a time. Your partner has been with you for 6 years. They moved cities when you matched into residency. They moved again when you matched into fellowship. The second move was discussed and agreed upon and was the right decision and cost something that has not been formally tallied, because some costs are better understood gradually than all at once. You have a dinner reservation for your anniversary on the 14th. You have been on call the last 2 anniversaries. You are not on call this year. You confirmed it 3 times. You are a good fellow. Your attending told you this at the 6-month evaluation in a way that carried specific meaning. Not the general encouragement that programs give to fellows who are progressing adequately, but the particular directness that attendings reserve for people they are planning to trust with difficult cases in the 2nd year. You received a difficult case the following week. You did not say anything about the connection. Neither did the attending. You both understood it. 1 year left. 1 year of watching and learning and operating under supervision and building the technical vocabulary of a specialty that takes a decade to fully speak. And then you will be an attending. And then there will be no one on the other side of the table. Level 6, attending surgeon. The first case you do alone is a lobectomy, right lower lobe, 61-year-old with early stage lung cancer, good functional status, straightforward resection. You selected it deliberately. You selected it because the anatomy is clean, and the margins of error, while real, are the margins you know best. You know you selected it deliberately. This is fine. Every new attending selects their first independent case deliberately. Nobody tells you to. Nobody tells you not to. It is one of the 1,000 things you learn by being inside the profession long enough to watch how it works. You're 32. Your salary is $385,000. After 15 years of training, during which your earning potential was essentially zero and your debt was actively growing, the number is real in a way that requires adjustment. Not celebration exactly, adjustment. You have a meeting with a financial advisor in 2 weeks. You have been meaning to schedule this meeting for 8 months. You scheduled it the week you signed your contract, canceled it once, rescheduled it, and it is now in the calendar and you intend to keep it. The lobectomy takes 2 hours and 14 minutes. There is a resident assisting you. You are on the attending side of the table for the first time. Partway through the case, you become aware that the resident's attention is not on the anatomy. It is on you, watching how you move, reading your cues for how worried to be. You remember being that resident. You remember reading your attendings the same way. You adjust your affect slightly, steadier, quieter, more deliberate in your movements, not because you are performing, because the resident in that room needs someone who is not afraid of what is happening, and you are that person now, whether you feel fully prepared to be that person or not. The patient does well. You write the operative note. You call the family. The call is 3 minutes long. You tell them the surgery when is planned, that the pathology will take a few days, that their family member is in recovery and will be moved to the floor this afternoon. The family member says thank you in a voice that carries the specific weight of gratitude that comes after fear has lifted. You say of course. You have said of course in this context many times during training, and it always landed as the right thing to say, and it still does. What is different now is that the gratitude is directed at you without the qualification of the attending's name above yours. There is no attending's name above yours. You are the attending. The first complication of your independent career happens in month 3, a post-operative bleed following a mitral valve repair. Not a failure of technique, a known risk. A risk you documented in the consent conversation, a risk the patient understood and accepted. The bleed requires a return to the operating room at 11 p.m. You take the patient back. You repair it. The patient recovers. The outcome is good. The outcome being good does not fully resolve what the event cost you. You reviewed the case twice in the 2 days after. You identified nothing you would have done differently. The review found nothing you would have done differently. You know this. What you are sitting with is not regret. It is the understanding, real now in a way it was not real during training, that you are the end of the line. When something goes wrong in your operating room, there is no attending to call. You are the attending someone will call. And that accountability is not a burden you were given. It is one you built toward for 15 years and chose and would choose again. But chosen burdens are still burdens, and the choosing does not make them lighter. It makes them yours. You are beginning to build a practice. Referrals come through the network slowly at first, then faster as your name accumulates the specific kind of reputation that surgical practices run on. Not marketing, not presence, but the quiet word between a cardiologist and a pulmonologist in a hallway about whose hands they would want on their own chest. That word travels at its own pace. You cannot accelerate it. You can only deserve it and wait. Level 7, Surgical Director. You stopped counting your operative hours sometime around year 6 of independent practice. Not because the operating stopped, you are still in the OR 4 days a week, but because the operating is no longer the only thing being measured. You are 42. You run the Cardiothoracic Surgery Division. That means 12 surgeons, 2 program coordinators, a quality improvement committee that meets on the 3rd Thursday of every month, a budget that requires quarterly justification to a hospital administrator who has an MBA and no clinical background and asks good questions about margin and asks fewer questions about outcomes than you would prefer. Your salary is $680,000. It is the number that follows 15 years of training and 6 years of building a practice and 2 years of leading a division. It is a fair number for what it represents. It does not feel like a number that requires explanation. It feels like a fact. The work has changed in ways you did not fully anticipate when you were a fellow imagining what the senior ranks looked like from the outside. You imagined more surgery. There is still surgery. Significant surgery. Complex cases that other programs refer, because your outcomes are in the top quartile nationally, and the word in hallways has compounded into a reputation that now roots the difficult cases to your division as a matter of institutional habit. But there is also the the administrative wait, credentialing, budget meetings. A conversation last month with a junior attending on your service who is struggling with the transition to independent practice in a way that is familiar to you because you struggled with the same transition and did not have someone to name it clearly for you. You named it clearly for him. You watched the recognition move across his face. That conversation took 22 minutes. It was the most useful 22 minutes of your week. You sit on 2 hospital committees. You are on the editorial board of a surgical journal. You have been asked to give grand rounds at 3 programs this academic year. You have said yes to 2 of them. You said no to the 3rd because it conflicted with your daughter's recital, and you have missed 2 recitals already. And the pattern of missing things is one you began to see clearly around year 8 of practice and have been correcting since, imperfectly, with the specific effort of someone who knows they are correcting a pattern rather than someone who never developed the pattern in the first place. The junior surgeons on your service call you for guidance on complicated cases, not always. Not for the cases they can handle alone, which is most of them, but for the ones where the anatomy is unusual, or the patient is high risk, or the decision about whether to operate is genuinely unclear. You take those calls, you answer quickly. You give direct guidance without removing the decision from the person who has to make it. This is something you learned from your own attending and are now passing forward without having named it as a lesson when you received it. Level 8, Chief of Surgery. There are 6,000 hospitals in the United States. Most of them have one. You are one of them. You're 51. Your total compensation is $1.1 million. It includes a surgical salary that has decreased from its peak because your operative caseload has decreased from its peak, and an administrative salary that reflects what it costs to run a surgical enterprise across 11 specialties, 140 surgeons, and an annual volume of 24,000 cases. You still operate 12 cases a month. You chose the number deliberately, enough to stay current, enough to maintain the credential that gives you standing when you walk into a room of surgeons and make a decision they disagree with. Without the operating, you are an administrator. With it, you are a surgeon who also runs the department. The distinction matters to the surgeons. It matters to you. You have not lost the thread of what this was for. The decisions you make now are systemic. Credentialing a surgeon whose outcomes data has a pattern you cannot yet name as a problem, but cannot ignore as random. Allocating OR time between specialties that each believe they are underserved. Building the case to the board for a robotic surgery platform that costs $3.8 million and will change the capability of 3 divisions and requires 12 months of training and a reallocation of scheduling infrastructure that 3 department heads have already objected to in 3 separate emails that you read the same afternoon and responded to with the same patience you use in a difficult case when the anatomy is not where you expected it to be. You trained for this without knowing you were training for it. The intern year built something. The fellowship built something. The early attending years built something. The division chief years built something. The accumulation is what is standing in this office right now at 51, making decisions that will affect surgeons who are currently in their PGY 2 year and do not yet know your name, and will train inside a department shaped by decisions you are making this quarter. Your oldest child is in medical school. She is on her surgical rotation. She called you last week from a parking garage at 5 a.m. to tell you she was nervous about her first day in the OR. You told her what you know to be true. The attending will not remember your nervousness. They will remember your hands. She said, "Okay." You said, "Okay." The call lasted 4 minutes. You did not tell her what the next 25 years look like. She will find out. That is the only way anyone finds out. The cycle. Right now, in a hospital somewhere, a 3rd-year medical student is holding a retractor. It has been 31 minutes. Their arm is beginning to shake at the shoulder. They are holding it still through the shaking because the scrub tech looked at them once, and they are not going to give the scrub tech a reason to look again. They do not know yet what they are building. They cannot see the chief resident year from the retractor. They cannot see the fellowship or the first independent case or the 2 a.m. call from a junior attending who needs someone to say proceed, or the board meeting where the $3.8 million platform either gets approved or doesn't. The distance is too far and the path is too specific to map from the outside of it. They know one thing. The attendings nod. They think it meant correct. It did. They will spend the next 25 years learning to give that nod themselves. To the medical students holding retractors behind them, shaking at the shoulder, holding it still, waiting to find out. The machine doesn't stop. It just gets new parts. And the new parts, if they hold long enough, eventually become the machine.